and today's subject is veterans and sleep disorders. But before we get into Joseph's slide deck, we wanted to share a snippet of an interview we did with a very important veteran who served as one of our patient panelists at last week's A.W.A.K.E Sleep Apnea Initiative. His name's Joseph Andrews. He's a Navy aviator. His nickname call sign was Dozer. And I think his story will speak for itself. So Joe, if you want to go ahead and play that, it's going to run for about 5 to 7 minutes, and then we're going to get into the webinar. So enjoy the show. Thank you.
So Don, first I'd like to just ask you, what was life before treatment for you?
Life before treatment was a lot of fall asleep during the day, or when I was not sleeping, being tired. I was in the Navy and in aviation. We got call signs. Before I got my official call sign, one of the ones that I got initially was Dozer, because I'd fall asleep in briefs. Driving a car was often an interesting event. My sister tells the story to this day that I was dropping her off at college, and we were going through the Hampton Roads Bridge Tunnel, and I went through the tunnel asleep while I was driving the car. She didn't want to say anything because she felt that I would swerve when I woke up, but it was hard, and I didn't realize. Just thought that I was, someone who was tired all the time.
Mm-hmm. And did it affect your profession at work?
Oh yeah, I had to. As I said, I flew, and it caused me concern. The airplane that I flew, we would normally fly 4 to 6 hour flights, and so there were times when I'd fall asleep in the airplane, and thank God for autopilot. But so I asked the flight surgeon for medication, which essentially was speed. And so I had that, but then there were some issues with that. Essentially, I couldn't ever sleep with that. I went through a period for 30 days on a ship one time where I was I never slept for about more than an hour a night. So I then discovered Ambien, so I would get a prescription for that as well. But you couldn't take Ambien when you were deployed. But so I just did the medication aspect. It was a horrible story for me at the time, but I was with a 4-star admiral. I was his aide. And we were on a VTC with the chief of naval operations and everybody around the world. And I was sitting behind him as he was on the VTC, and I fell asleep and I snored. And so that went out to the VTC, and he turned around and yelled at me and said, "God, you have to wake yourself up." And it did affect me.
Wow. So then what was life like after treatment?
Treatment for me was really a kind of 2-stage process. I was, when I first got diagnosed, I was still deploying, so I couldn't get a CPAP machine, and they gave me an oral device. And that helped. It certainly helps with the snoring aspect. But in fact, it was after that event that I just talked about with the MRI, I said, something's not working here. And I knew I had sleep apnea. I knew there were CPAPs out there. So I went and got another sleep test and got the CPAP machine. And I remember the first period after using the CPAP machine, it was a marked difference. I felt like it was, that's what good sleep, what real sleep was like with that machine. But there were drawbacks for me, and I stopped using it. And this has brought back to memory for me how good I felt with it, and so I'm going to start using it again.
Mm-hmm. What were the drawbacks?
The 2 major drawbacks were the woman who I was with at the time, my partner, didn't like it and complained. It said, she would say to me, "You don't need that. Use the mouthpiece." And then the encumbrance with the cord were the 2 things that really caused me the most problem with it. I did have some minor concerns, and I think she planted the seed, to be honest with you, that you know, you risk infection with bacteria in the hose and whatnot. But those were the two big ones.
Maybe you're looking for a little excuse not to use it.
Yes.
Yeah.
Yeah. Although I really like the way I feel when I do use it, so
So it worked when you used it.
like you read about.
Technicolor.
Yes. Yeah.
So what advice would you give others, given your experience so far?
The machine works. Figure out how to use it. I think that I was never taught how to push the buttons or how to put the mask on or anything like that. And I think that there's some technique, because I can tell when I have a seal and I don't have a seal. But it does work. I think that there may be some alternatives with the old device, but that's not giving you the pressure breathing, and I think it's really effective. For those who, you know, sleep apnea is an underpublished disease. If you want to call it this, I guess it is a disease. And, you know, many times I often felt, well, you know, you're not measuring up because you're falling asleep here during the day. And, you know, with the people that it doesn't happen to, what's the difference? Well, you must be lazy or whatever the thing is. But
there's a kind of an inherent bias, isn't there?
it really is,
that you're weak if you're not, you know, able to stay awake.
You know, I can't tell you the number of times I myself will sit around the room and see the people fall, you know, dozing off. And, wow, you're a real slacker. How come you didn't prepare properly or
We're
whatever.
taught to be judgmental. And that,
It is just, there's a stigma associated with it. There really is.
So how do people get over the stigma? What advice would you tell somebody?
I don't know. Maybe there's the awareness for sleep apnea would probably help a lot. You know, that I know I see people now. In fact, there's a guy at work. I could tell instantly that he had sleep apnea because I could just hear him yawning over there. See him doing that. He fell out of the chair one time at his desk, which I've done before too. I said, "Hey, Mike, you know, I think you have sleep apnea. You need to go get checked." It took him. He went through the VA, and it took almost a year, but he ended up getting a machine, and he came back and said, "I can't thank you enough for that." There's not a big awareness of the disease, of the effects. You know, treat it with coffee. Or treat it with you know, medication or the effects of it, not really the disease itself. So.
Well, that's great. So we want to thank you for taking the time to talk with us and talk about it with others. I think it's hard to kind of get a handle on how many people you can positively affect. Personally, you know, I've done the same thing. I've talked to people, and then they'll come back a couple of years later and tell me, "It saved my life. It saved my marriage. Thank you so much." And it was a small gesture on my part, but it really paid off for some people. And so, you know, being an advocate like you are was really important. Thank you very much.
Well, thank you for having me.
So thank you, Joseph.
What was life before treatment for you?
You want to switch views there? So that was Captain John Andrews and Will Hedipole, our board chair emeritus, doing a patient-to-patient interview last week during our Awake Sleep Apnea initiative. And as you can see, it's very poignant as far as the subject matter of today's webinar. With that, I'd like to introduce Joseph Anderson and let you take it away from here, Joe.
Hi, Theresa, did you want to jump in here or you want me to go ahead?
Just go ahead.
Okay. Well, why don't you discuss the housekeeping here and then I'll...
Okay. Well, at the end of the session, we will likely open the mic up so that people can ask questions. If you would like to raise your hand, there's an icon for that. And if you would like to just type your question in rather than go live on the mic, it's up to you. And if you're watching the recorded version and you have questions, you can write to us at ASAA@sleepapnea.org. Okay.
All right. Well, I will take it from there. Good morning and good afternoon, I guess, depending on where you are. What a great video. I mean, the quality of the video was fantastic. It's nice to hear from another veteran. I myself am also a veteran, an Army veteran from the 329th Army Security Agency, a division of the Military Intelligence, 2nd Infantry Division. So, little bit of background on me. I'm credentialed in education, sleep, neonatal respiratory care, and pulmonary function. Been doing this for well over 33 years now, probably closer to 34. I have authored a couple of things along the way. In fact, I've got a new textbook that'll be coming out later this year. And I live in Virginia. But more importantly, for what we're talking about today is I supervise a 12-bed integrated sleep disorder center at McGuire VA Medical Center. So very familiar with veterans and the problems that we have with sleep disorders. I do want to put my disclaimer out here, though, to remember that I am not a physician. Wish I was, but I am not. So, but I am an educator and a technologist, like I said, with more than 3 decades of experience. So what I'm going to present to you today is general information, but just understand that I can't offer medical advice or do a diagnosis. But with that said, is I can make suggestions and I can answer some questions and hopefully give you some information. So let's look at some objectives that we're going to try to talk about today, and we're going to look at an overview of some of the more common sleep disorders that we see in our veteran population. We're going to look at some characteristics that may contribute to the veterans having sleep disorders. And we're going to talk some about how us veterans can seek help for our sleep disorders. And then some sleep disorder assistance is available specifically for the veteran population. Now, even if you're not a vet, this is good information to know because there may be somebody that you know that is a vet, and you can pass this information along to them, or maybe you just want to be a little more educated yourself. All right, so let's first talk about the difference between respiration and ventilation. Respiration means the air that's moving in and out of your lungs. Inhalation and exhalation. You inhale and you exhale. And we, by nature, we breathe through our nose. The only time we really don't breathe through our nose and start to breathe through our mouth is if there's a reason to have to do that. There's something going on with our nose, we have an allergy, we have a physical condition that's keeping us from doing that. We are exercising a lot, for example, and we may need a lot more air moving in and out of our lungs. But respiration is simply the method of getting air in and out of our lungs. Ventilation, technically, it takes place down inside of our lungs, deep down in our lungs, and that's where we actually do an air exchange where we will remove the CO2 out of our body and replace the CO2 with oxygen so that we can feed the cells in our body. Now, the reason that's important is because the majority of the sleep disorders that we're going to see, not only in the veteran population, but in the private sector, has to do more with the respiration side of things. In other words, getting the air in and out so that it can get down to the bottom parts of the lungs to be able to do the ventilation. So we're going to talk about some of the common sleep disorders that we see in the vets. There's basically 3 types of sleep apnea. There's obstructive sleep apnea, central apnea, and mixed apnea. And we're going to talk a little bit about all 3 of those, but we're going to focus mostly on obstructive sleep apnea. And that's because that's the type of apnea that affects most of our vets. And if we were to take and characterize what we're looking at, if you see right in the middle the sleep apnea, and I don't know if my mouse shows up when I move it on the screen.
It does.
Okay, perfect. You can see all these different problems that all can find their roots back in sleep apnea. And that's dementia and memory loss, for example. And we can look at stroke and headache and heart attack. We can go through these fatigue, drowsiness, obesity. So many of these things have their roots in sleep apnea. And some of them are basically the chicken and the egg kind of thing where we don't know which one came first. Maybe the obesity came first and it contributed to the sleep apnea, or maybe the sleep apnea came first and contributed toward the obesity. But what we do know is we have this whole spoke collection of problems that have some stems back to sleep apnea. So when we look at the veterans parts of sleep apnea, we're going to see that statistically, according to the U.S. Department of Veteran Affairs, 1 out of every 5 war veterans has been diagnosed with obstructive sleep apnea. Now we compare that with only 1 out of 100 civilians are diagnosed with sleep apnea. And even that's a huge number. I'm sorry, 5 out of 100. 5 out of 100, that's a huge number. So when we look at 1 out of every 5 veterans, that's an even larger number. So when we look at the specific veteran population, we can see that overwhelmingly we have an obstructive sleep apnea problem. And if we go back statistically and look back to 2008 and 2010, we're going to see that the number of veterans who received medical benefits, not necessarily service connection, but medical benefits related to sleep apnea grew by more than 60%. I can tell you now that we're waiting for some numbers in 2018, and we're going to find that that growth is continuing to grow by leaps and bounds. So these numbers beg the question, why do war veterans suffer from sleep apnea more than non-war veterans, and particularly civilians? Well, some of the VA doctors believe that this is due to the high number of repeat deployments that our vets are going to Iraq, Afghanistan, and even back in Vietnam. We saw soldiers were being exposed to high levels of dust, smoke, stress, and violence. One of the things we're seeing with today's vets is these multiple deployments that I mentioned. Some of these guys and gals are going back 3, 4, 5, even 6 times to one of these war zones. We didn't see that a lot with Vietnam. Often, if you went once, you may have gone twice. But these wars that we're having now have been going on for so long that these career military personnel are finding themselves deployed more and more back to these war zones. So what's the core of this connection between war, obstructive sleep apnea, and other related conditions such as daytime sleepiness, memory loss, as I mentioned a little earlier, even a decrease in work productivity, obesity, heart disease, diabetes, hypertension? Well, and I put in quotes here that there's a Dr. Arnett's that believes that it may be the stress of war that leads to the fractured sleep, and that no one had really explored the possible link before, although basic research suggests that this is a plausible answer. If you can just imagine, many of you that are veterans have probably been deployed to either Vietnam or one of these Gulf areas. But even if you weren't deployed and you were still in the military, just the fact that you were in the military for any extended period of time brings with it its own stress levels. And those are levels that may or may not always be seen in the private sector, because remember, you were once in the private sector, and some of you are in the private sector again. So you're not only experiencing what you had while you were in the military, but you're also experiencing what all the rest of us feel in the private sector. So those who left Iraq after the war after it started, and also suffered from mental disorders such as post-traumatic stress syndrome and depression, and those that rated their physical health as worse than their actual health were 43 times more likely than pre-Gulf War vets to report obstructive sleep apnea. And later, a lot of these vets have developed major chronic health issues such as cardiovascular disease. We know there's a direct connection between obstructive sleep apnea and cardiovascular disease. Now, does that mean that everybody who has cardiovascular disease has or has had sleep apnea? No. Nor does it mean that if you have sleep apnea, you're going to get it or develop a cardiovascular disease. But we do know that they are connected for some people. So if you have some level of PTSD or you have some level of depression, and you do rate yourself physically worse now than you were before you were deployed, it's very likely that if you don't treat your obstructive sleep apnea, that this could lead to some of these other comorbidities that we're talking about, such as diabetes and cardiac issues. We know that it's a known fact that the more exposure to violence anybody has, the more likely that they're going to report post-traumatic stress disorder. And if they develop PTSD, they're also likely going to develop depression. And also we know that the worse you rate yourself, the more likely your actual health will suffer. So what is obstructive sleep apnea? Well, we have a couple of pictures here. The one on the left is non-obstructive and the one on the right is obstructed. If we look, we're breathing through the nose. Like I said in the beginning, we normally should. We come down through the airway and we go down into the lungs. Anytime we're talking about obstructive sleep apnea, this is where we're talking about it occurring. It's in the upper airway somewhere. Now, if we look over here on the obstructed side, notice that we're not just breathing through our nose anymore, we're also trying to breathe through our mouth. And the reason for that is as we're breathing through our nose, we hit this obstruction. It's not over here, but it is over here. So we've hit this obstruction, which means now our body's still going to try to breathe, right? We still need to be able to respirate. So we try to breathe through our mouth, and it too ends into a restriction or an obstruction as it's trying to go down into the airway. So again, obstructive sleep apnea is the most common type of sleep apnea and is caused by either a complete or partial obstruction of the upper airway. Now, if we look in the airway, there's a lot of stuff going on in here, but any of this can become enlarged or obstructed and cause us to have some sort of problem. Now, could be that it's just the way your body's built. It could be that you've gained weight or even suffered some type of physical trauma to your upper airway. But a lot of times people will experience obstructive sleep apnea even for a short period of time. Children, for example, will often have obstructive sleep apnea or some type of restriction, and they end up having some surgery to open the airway up. Or we can have a respiratory infection or a nasal congestion that causes a swelling of the throat or our upper airway that might temporarily produce an obstruction. Now let's look at nasal obstructions. During sleep, we are obligated nose breathers. That means that's how we want to breathe, is by through our nose. And we only transition to an oral breathing when there's something that disrupts our pattern of breathing. You can see up here that there's some swelling going on. Again, this could be allergy related or any number of different things, but trying to breathe through their nose, it hits this restrict a little bit through, but then you have to breathe through your mouth to get some more through. So a nasal obstruction tends to collapse the nasal airway, and it results in us having to breathe through our mouth. So how do we diagnose obstructive sleep apnea? Well, there's a couple different ways. We're going to start on the bottom of this slide first. This is one of the more important ones. We look to the bed partner. If you have a bed partner and if you have some type of apnea, oftentimes the bed partner will know that because he or she will see and hear you gasp for air or snort or snore, or they might even see you have a complete cessation of breathing where you're not breathing at all. And we're going to talk about that in a minute. So a lot of times us veterans, we're brought to a sleep disorder center because of our significant other or our bed partner that is tired of hearing this, or quite frankly, maybe just scared of hearing it. So there's two types of studies that we often do now. One is a home sleep apnea test, and that's a test that you actually take home. You may go into the sleep center and they teach you how to do it, or they may send it to you through UPS or FedEx or something along those lines. And what we're doing with that test is simply to rule in or rule out that you have obstructive sleep apnea. Obstructive sleep apnea is only one of many, many, many different types of sleep disorders. But a HSAT, or a home sleep apnea test, is a great way to rule it in. Now, if it rules it in that you have obstructive sleep apnea, you may be given a Cpap machine, which will provide some positive airway pressure to keep your airway open. or you may be asked to come into the sleep center for further studies. Now, if the HST does not show that you have sleep apnea, then we're probably going to bring you into the sleep lab anyway, so that we can figure out what else might be going on. And that's when we do a polysomnogram or polysomnography. We call it a PSG for short, but it's an attended in-lab study where we put all kinds of sensors on you, all over your face, all over your chest, on your legs. We look at your pulse oximetry. We look at your heart rate. We look at your EKG. We look at a lot of different things because we're going to try to figure out what's going on with you. Now remember, obstructive sleep apnea is the more common, but there are other things besides just obstructive sleep apnea. So when we bring you in for this PSG, we're going to look at a couple of different things to help us determine whether you might have OSA. One of that is we're going to look at a 90% or more reduction in your airflow. Whether you're breathing through your nose or your mouth, we're going to look to see if you have a 90% or more reduction. Now we're going to see if that lasts for at least 10 seconds. And we're also going to see if your chest and your stomach are actually trying to breathe air in. Remember, you're trying to respirate to bring that air in, and we're going to see if we can see if there's a problem. So if we look at this, and this is what we call an epic as part of a sleep study. There's a bunch of squiggly lines here, brain waves and things like that, but we're going to focus right here. This is where you are not moving air in and out of your nose or your mouth. Clearly, this is a 90% reduction or more because this over here is where you're breathing, okay, going in and out. And then you have another 90% or more reduction. Underneath that, these are your belts. These are belts we put around your chest and your abdomen where we can see that you are trying to breathe. Your chest is going up and down, your stomach's going up and down, you're trying to breathe, but clearly no air or very little air is moving through. That's a classic example of obstructive sleep apnea. Now we have another type of apnea that's far less common, and it's called central sleep apnea. And we see that in less than 10% of our patients who have a sleep disordered breathing. That's not 10% of the entire population. That's 10% or less of people who have some type of sleep disordered breathing. And in this case, we're likely not going to send them home on a home sleep apnea testing device. We're going to bring them into a sleep lab, and we're going to do a full-blown PSG to see what's going on with them. But we're also going to do the same type of questionnaire with their bed partner. And what we're going to look for in a central sleep apnea is absolutely no air or no effort being moved in and out of us. Okay, so we're looking at 100% reduction of nasal oral airflow. Whereas before with the apnea, we were looking at 90% or better. With a central sleep apnea, we're looking at 100%. Again, lasting at least 10 seconds. And this time, we don't want any chest movement or stomach movement. So if we look at this example, we can see again, there's no air moving in and out, but this time there's no effort either. Right? So breathing okay over here, have some effort going on, chest and stomach, and then we have a complete cessation of movement of air or any effort. Now, there's some theories behind central sleep apnea. We're still not really clear as to why it happens. It is, we consider it more of a neurological disorder because something along the lines of this is either your brain is not telling you to breathe, so you're not, or your brain is telling you to breathe, but that signal is not getting to where it needs to get to in your body to have you breathe, which is different from having that upper airway obstruction that we see in OSA. So any neurological disorder affecting the metabolic control system, which means all the chemical balances in our body, could contribute to having central sleep apnea. Any type of trauma to our brain or our brain stem, something along those lines, even tumors could cause central sleep apnea. Or sometimes we'll see it in various muscular diseases such as myasthenia gravis, muscular dystrophy, and things like that. Now, I don't want you to think if you have central sleep apnea that you have a brain tumor. That's not what I'm saying. What I'm saying is that there are a lot of things that can contribute to central sleep apnea, and it's a great area of research that we're still looking at. it's pretty clear what causes obstructive, but when it gets to central, we're still trying to figure out some of these things. And then we have, just to complicate it a little bit more, we have something called mixed sleep apnea. And again, we would bring you in to the sleep lab if we thought you might have mixed sleep apnea, because it is not only a component, it has components of obstructive sleep apnea, but it also has components of central sleep apnea. So we're still going to look for that 90% or more reduction in airflow, lasting at least 10 seconds. But this time we're going to look for a little bit of central and a little bit of effort underneath it. So if we look at, again, one of these waveforms here, we're going to see where there's no air movement up here, clearly 90% or more reduced, right? Same thing over here, you can see it happening again. Now this patient happens to be in REM sleep. Just as a side note, you can see the eyes that you would see moving around in REM sleep. But if we look under this apnea, we're going to see two things. We're going to see a central component and we're going to see effort. And that's what we're looking at in the mixed sleep apnea is we'll see that there's no breathing, we'll see that there's a central component, but we'll also see that the patient will try to breathe again here. And then eventually they'll have that snort where they'll start to breathe again, and then chances are they'll go right back into the same pattern. So this would be called a mixed sleep apnea. So we said in the beginning there's basically three types of apnea: obstructive sleep apnea, central sleep apnea, and mixed sleep apnea, with obstructive sleep apnea being the more prominent one. Now, again, that can be for a lot of reasons. We talked about it maybe being from deployments and things like that and stress, but it can also simply be a factor that we're getting older, we're getting heavier, possibly even fat, right? We also see a higher tendency in these types of things in males. So a lot of times we'll see it in our vets where maybe they didn't have this when they came back from Vietnam, you know, all these years ago, or when they came back from Desert Storm or something along those lines. But now, you know, now they're 35, 45, 50 pounds heavier, and we're beginning to see some of these sleep disorders. So it may or may not be related to the deployment, but we just don't know that. And that's one of the things that we're trying to figure out in the veteran community. I'm going to go back to the slide. Let's look at two things. Sleepiness. How do we rate sleepiness in a sleep disorder lab? Well, we're looking at two different scales: the sleepiness scale and the frequency of this. So if we're looking at just a sleepiness scale, if you have mild sleepiness, which means excessive daytime sleepiness, you're sleeping a little bit here and there, it's probably not much of a bother. Moderate would be if it does become a bother to you. And of course, severe would be if this is a constant struggle for you to stay awake. When we do the sleep study, whether it's a home sleep apnea test or whether we do a PSG in the lab, we're going to look at the frequency. Are you having these events, say 5 to 14 times an hour, or 14 to 30 times an hour, or in some cases 30 times or more an hour? We're going to rate that as mild, moderate, and severe. Now, in my career, I have routinely seen people who have events more than 100 times an hour. That means more than 100 times an hour, you either stop breathing for 10 seconds or more, or your breathing becomes restricted for 10 seconds or more. So some of the consequences, again, of having sleep apnea could be sleep fragmentation, where your sleep is disrupted. You could have some cognitive dysfunctions. Cognitive meaning the way you relate to people in your life every day, whether you're sleepy, whether you're argumentative with people in your life. Again, if you gain weight, you could have obesity hypoventilation. Now, if we break that down, hypo meaning less than, and of course we talked about what ventilation and respiration mean. Excessive daytime sleepiness. Cardiovascular stress we talked about. Hypoxemia or hypercapnia. Hypoxemia means low oxygen in the blood. If you have low oxygen in the blood, you're going to have high levels of CO2. Remember when we talked about ventilation occurring deep in the lungs, that's what we're trying to do, right? Respiration is bringing the air in and out. Ventilation is taking out the CO2 and replacing it with oxygen. If that doesn't happen, we're going to have low oxygen, hypoxemia, and high levels of CO2, hypercapnia. There's another type of sleep disorder called a hypopnea. Now, a hypopnea is when we have only a 30% reduction in airflow. OSA is 90%, central is 100%, but a hypopnea is 30%. Again, it has to last for at least 10 seconds. And we will have chest movement because we're trying to breathe. But what we're also going to see is either there's going to be an arousal where the brain is going to wake up even if we don't know it's waking up, or we're going to have a drop in our oxygen levels. In either one of those is bad. If our brain is waking up and we don't know about it, it's going to help contribute to excessive daytime sleepiness. We're going to have all these brain awakenings that we have no clue are happening. If our oxygen levels drop because of apneas or hypopneas, what that does over years and years and years of abuse, it begins to destroy our body. Okay? It can begin to damage our organs, and it can throw us into all kinds of other health issues. So on this slide here, we can see that we're breathing, and we have a reduction. Not flat line, not a 90% reduction, but we do have a reduction. But again, we continue to have effort. Look over here. This is your oxygen level, and notice that your oxygen level is way up here while we're breathing, but as soon as we have this reduction, our oxygen level begins to drop off. And this is what contributes to some of the damage from long-term untreated sleep disorders. So let's look again at some specific veteran characteristics that might contribute, and then some of our risk factors. Obesity, I mentioned that already, right? Where we tend to gain weight as we get older, and again, the male gender, but we also could have some of these neurological disorders that we may or may not have been aware of years ago that are beginning to either surface now, or we had them all along and we just didn't deal with it. Again, PTSD or even TBI, some type of traumatic brain injury, could put us at a higher risk. Some of the other issues that we talked about, the comorbidities, again, that's the chicken and the egg. Did we gain weight because of the sleep disorder, and did we develop a cardiovascular disease because of the sleep disorder, or is it just the opposite? How about family history? We find that a lot of times some of these issues are what we call familial, which means they do run in families. Alcohol or sedative use, huge contributing factor among our veteran population. Even smoking or drug use. When I was in the Army, and I got out in 1980, when I got out of the Army, I can still remember getting rations that had the cigarettes in them. Okay, a little package of cigarettes along with our John Wayne bars, our candy. Obviously, they don't give cigarettes out anymore to our military. I can remember in boot camp being told smoke them if you got them, kind of things. I don't think that happens anymore. So a lot of our veterans, though, came out of the military service, went into the service, came out of the service as smokers, and unfortunately, a lot of them continue to smoke to this day, and many of them have developed some drug use habits. Your historical work environments, what did you do in the service? Okay, what were you exposed to in the service? My quick story on my uncle who, from South Florida, decided to go into the Florida National Guard to avoid a trip to Vietnam. He was a medic, and lo and behold, not more than 2 months after he went into the Florida National Guard, his unit was activated and he went to Vietnam.
Funny how that works.
Yeah, he was there for a good long time. But the reason to bring it up is he was exposed to Agent Orange, and he is just now beginning to suffer some of those significant consequences from that. So your work environment definitely can be a contributing factor. So how do we as veterans seek help for a sleep disorder? Well, we have to get it diagnosed, right? So diagnosing OSE in veterans can be a little trickier than non-veterans because of the possibility of our military-related medical conditions. In addition, some of us that have suffered may actually have underestimated the health benefits of restorative sleep. And that's where our organization, the American Sleep Apnea Association, comes in, and we educate. That's why we're doing things like this, so that we can talk to people about the importance of sleep, and not just sleep, but good quality sleep. So a lot of our veterans really didn't think about this, and rather than being properly diagnosed and treated, we just accepted this fractured sleep pattern as it's just me, or it's a part of getting older, it's a part of life, and in some cases it may be that, but in a high percentage of these cases, it's not that. It's an underlying sleep disorder that either hasn't been diagnosed and recognized yet or isn't being treated.
Joe, I'd like to say something. You know, talking about the education for our veterans and for everyone, and veterans and spouses that might be listening today, I just wanted to take this opportunity, and you too, Joe. Thank you for your service. I believe the spouses give service just as the member does. But if you know someone that is having an issue after serving, this is what we're here for with the sleep problems. I mean, and there's so many things, and we do get mail, but be sure and join the A.W.A.K.E group on Facebook, or just write to us, and we will try and help you. Thanks, Joe.
Absolutely. You're absolutely correct, Theresa. And I have a spouse too, so she'll vouch for that. So what about treatment? Well, more and more Iraq and Afghanistan veterans are realizing that their post-war health problems, as well as some of our Vietnam and Gulf War veterans, as they get older, realize that the number of veterans applying for OSA-related disability benefits will continue to rise in the coming years. That's very important. My lab in Richmond has doubled in capacity over the last 3 years. So we know that OSA is a chronic condition. It's creating a significant burden on the veterans' healthcare system. And the VA spends way over $500 million a year to treat veterans with sleep apnea. That's just to treat their sleep apnea. That's not counting treating all the other comorbidities that may be associated with that. But we really expect this number to go well over $1 billion in the next couple of years. So what do you do if you want to get some help? Well, the first thing you do is you need to discuss your symptoms with your primary care provider. That's your VA hospital primary care provider. If you want help from the VA, you have to be within the VA hospital system. This means that the VA doctor will not accept outside referrals for a sleep study. We also will not accept outside referrals to meet with a sleep doctor. Okay, so you have to come into the system, which isn't that difficult, and go through the process. I believe that in the video, the gentleman talked about it took almost a year, start to finish. That's probably because he was never in the VA system to start with, the Veterans Hospital system. So you need to do that. And then be sure to discuss anything that's going on with you, any excessive daytime sleepiness, any snoring, maybe you have nightmares, maybe you have insomnia, or any other problem that might be associated with your sleep. But again, the key is to get into the VA system, because you're not going to be able to go to your doctor outside of the VA, get a referral for a sleep study, and have it done within the VA. And there's a lot of reasons you want to come in and have this done in the VA hospital system rather than in one of the private labs outside. You can certainly go do that, and the VA supports your decision to do that. However, there's a lot of things that are really specific to us as vets that the private sector may or may not be ready to deal with, or even comfortable, or even knowledgeable to deal with. So again, I recommend you get into the VA system. So ask for a referral to the VA Hospital Sleep Disorder Center once you're into the VA. And again, remember, any referral to see a doctor needs to come from within the system. So most of the VA hospitals have a sleep disorder center. That's mine pictured there at Hunter Holmes McGuire in Richmond. But we also have things called community-based outreach centers, which are CBOCs. And some of those CBOCs might have some sleep services available. They probably won't be doing the in-lab studies, but a lot of them will have access to those home sleep apnea testing devices that we talked about. or even the ability to go there and get the CPAP machine, positive airway pressure machines, to be able to treat some of your issues. So if you're diagnosed with apnea or hypopnea, you're probably going to be placed on a PAP device such as CPAP, which stands for continuous positive airway pressure. And if you are, and if you're in the VA system, all of your equipment and supplies are going to be provided to you. Okay. Often this equipment and the supplies are provided with little to no out-of-pocket expenses to us as veterans. Your sleep disorders care will be through the sleep provider specialist within the sleep disorder center. In other words, you'll become a member of our family for the sleep lab, and we will follow your care. And we will bring you back probably on an annual basis to see how you're doing.
Joe, can I make a shameless plug for our CPAP assistance program here? Because for all those vets who are using oral appliance or other interventions for their therapy, whether PAP related or combination, we could use any donated machines that are lying around or sitting in closets. They're not doing any good since they're not on anybody that could be using them. The VA is not allowed to take them back, so we as a CPAP assistance program are actually one of the few organizations in the country set up to be able to take them in, refurbish them, and get them back out to patients or maybe non-active veterans or people that are not in the system to get the machines. So just wanted to put that out there.
It's a great service that the ASAA offers, and you're right, we are not allowed to take equipment back because we don't have the facilities to be able to clean them, first of all. And secondly, we know that when our vets come to us, they want new machines, so we will give them new machines. But we also know that we have a lot of, CPAP isn't for everybody. There's a lot of different treatments for the sleep disorders. CPAP is one of them, so we have vets who will get a machine that may or may not use it at all, or they may use it for a very short period of time, and those are great, slightly used machines that the ASAA would love. Now, Adam, do you guys pay to have those things shipped to the ASAA, or?
I wish we were that flush where we could, but we were happy to give a contribution tax letter, just like when you stop at Goodwill or anywhere else. They give you a receipt and they let you fill it out for what your donation should be.
Well, my CPAP machine's worth $10,000. I don't know about everybody else's. For tax. Mine's very expensive. And I am on CPAP, by the way. Okay, so you're going to, if you're diagnosed with another sleep disorder, and again, remember there's all kinds. We mentioned insomnia, but there are others. You may also be part of what's known as an integrated sleep disorder approach, which you may be working with a dietitian or a cardiologist or a pulmonologist or a cardiologist, any number of different people that are going to step in and work as a team to help treat not only your sleep disorder, but anything that's related to that. And then we'll monitor all this because we have a great VA record management system. And in fact, if you leave your VA hospital and go to a different VA hospital, your records can be moved to those facilities as well. So once you're in the system, we'll keep you in the system forever and ever. Now, another thing that we do is the VA is also actively involved in looking at all the most current diagnostic and treatment care anywhere in the world, that's available anywhere in the world. In fact, one of the things that we do is called Store It Forward and Telesleep. And what that means is it allows us, as your sleep providers, to be able to monitor your use of the CPAP machine, for example. We have modems in there that will send us information. Now, this isn't available at all the VA sleep labs, but it's becoming increasingly available, and it is available at mine. Every CPAP machine that we put out has a modem, which means we can monitor your usage of it, and we can make some tweaks and changes along the way, which will prevent you from having to drive all the way in to a CBOC or into the main hospital. And then the telesleep allows us to be able to meet face-to-face from one computer to another. Now, sometimes this telesleep is done from a group environment, maybe in a CBOC, but we also have some sleep centers that are able to do this to vets right in their own home if your home has the internet accessibility to be able to do that. And the Veterans Administration is one of the key places that is really doing a lot of research on telesleep. Telehealth has been around for a while now where we can do various things, but telesleep is kind of on the new, it's one of the new programs that we're really looking at doing. And the reason we can do that in the VA is we're not so hung up on trying to get reimbursed from a payer out there to do that. And a lot of your private sector labs won't do things unless they can get paid for them because there is a cost involved, right? And they want to get not only reimbursed, but to turn a profit. Something else that we're doing, and we've done it at my lab, and I know it's being done in various labs across the VA system, is upper airway stimulation technology. And it provides a fully implanted device in your chest and a little wire that goes up to your neck. And if you are interested in looking more information on this, not plugging the company that we use other than the fact that I can give you their website. And I believe it's inspiresleep.com, www.inspiresleep.com. But check that out, and you can, it's a very expensive procedure, but it's also a very small patient population that can use this device. But if you can't tolerate CPAP, what this device does is it basically gives a little stimulation to your tongue, pulls your tongue forward, opens up your airway, and allows you to respirate. Something else that we're doing within the VA system that's pretty cutting edge is called REVAMP. And REVAMP stands for Remote Veterans Apnea Management Program. This is a program where we're going to be able to collect some of that information I talked about in the modems. Well, there's different manufacturers of machines, and they all have different types of software to use. Well, the REVAMP program is going to allow us to collect information regardless of who the vendor is that's providing this equipment. And we can look at it, and again, we can make changes, the providers can do that, but we also will have the ability to work with you on a web basis or an internet basis and be able to provide education through the REVAMP program. So it enables us as veterans to receive not only a diagnosis and treatment for our OSA without having to travel to another VA medical center, but it also gives us the ability to maybe manage our supplies as well. And we rolled it out to about 10 or 12 sites now, and it's expected, if everything works out well, that it's going to go much more national scale over the next couple of years. So it's called REVAMP, Remote Veterans Apnea Management Program.
This is Carl. Can I say one extra thing about REVAMP?
Yes, sir.
We just won a 2018 Federal Health IT Award this past week at the National Press Club, one of about 20 award winners throughout the federal government for innovative products. So we're really excited about the REVAMP platform. But Joe, you're right, it's been deployed at 10 sites, looking to get up to about 30 within the next few months or so. We're really excited about it and the extra education and effects positive outcomes
Awesome.
for patients. So thanks for bringing it up.
Yeah, it's great because it's been a program that's been in development for several years now, right, Carl? And
Yeah,
it's
sure has.
a long journey.
Yes.
Nothing in the government moves fast, right?
No, that is for sure.
And this seems to be more painstakingly slow than other things.
Yeah, and it's really because they want to make it enterprise, so it really integrates with other VA offerings like My Healthy Vet and DS Logon, and so
Yep.
and integrate with CPRS as well. But some of these take quite a bit of time to make happen. So
Yeah, anytime you go across various platforms, it takes a lot longer.
yeah, yeah.
The other thing that the VA is very adamant about is continuing education. All the providers, whether we're medical providers, technologists, technicians, clinicians, whatever's going on, all of us, all the technical staff included, are required to complete annual training for veteran safety and to stay abreast on all the improved patient care modalities within our specific professions. And we do this through hands-on education, online education, and participation in symposium and conferences. It's real important to the VA because we, in many cases, we exceed what's available in the local community for our veterans, for the assistance that and the expertise that's available. There's a lot of things, a lot of programs that happen in the VA, again, as I mentioned earlier, that can't start or happen in the private sector only because of the funding issues. But again, it does take time. So I hope that we've answered some of your questions. I hope that we've given you some information that's helpful. And Theresa, at this point, I turn it over to you for any questions that anybody may have.
It doesn't look like we have any.
Oh, I answered everybody's
Facebook. In the Facebook, pardon?
I said I must have answered everybody's question then.
Yeah. Oh,
yeah, that was a pretty comprehensive slide set, Joe. Thank you for bringing that and sharing that with our audiences, and for those that are in the military and those are not, and those are families of. I'm sure they could be get a lot out of that. I sort of wanted a bookend, you know, the interview we watched before your meeting, just to give you sort of an update. Unfortunately, and Captain John Andrews actually had a TIA incident after our meeting, which really tells you how serious it is, and he'd be the first to tell you that you got to wear this machine every day. It's just like putting on your glasses, as Rick Gordon said at our meeting. It's, you know, it's the first thing you do before you go to bed, and it's the last thing you do when you wake up. So, you know, it really hit home when that happened, because it's you know, even that 2-week waiting period for patients like myself who, you know, got diagnosed and then had to wait 2 weeks for the insurance to kick in. That gap is just not ethical. It's not right, and we need to really, you know, remove that in the sort of healthcare system. So I want to thank you for your service. I want to thank you and your patients for what they're doing. Any way we can get help to patients in or out of the system, you know, that's what we're looking to do. We're looking to remove barriers and obstacles and look out for the patient's best interests, or that or their families or caregivers, whether it's through our Cpap assistance program, or A.W.A.K.E, Alert Well and Keeping Energetic in person or virtual network as part of our web assets. And then, you know, hopefully getting people onto the wellness side and the early recognition of sleep and sleep apnea issues in our lives. And you know, because one thing we learned coming out of our meetings is that there's, you know, not a year, not 10 years, not 20 years. We're seeing multiple decades where this could be, you know, really, whether it's chicken or egg is not even the conversation anymore. The bottom line is, we know if we start treating early, that the long-term benefits to the person, to the society, emotionally, mentally, physically, in every which way is just where we need to go with this field. So
totally, Adam. I couldn't agree with you more. We do have a couple of questions that came in on the Facebook feed. Do we have a moment or two to read those? We have a question from Patty, and she says, I have a question regarding my CPAP machine. I'm going away and don't have Wi-Fi. Will my machine still work?
Absolutely. The machine will keep the information within the machine, and it'll store it. It has, without having the Wi-Fi hooked up, has no effect on the controls of the machine whatsoever.
Okay. We have one from CJ. I am a U.S. Air Force veteran who has 10% rating for respiratory issues and have been diagnosed with severe apnea by the VA and even prescribed a CPAP machine by the VA. Any recommendations to try and get the percentage increased? Anything I should be doing?
I don't have an answer for that.
Okay.
Well, I do have some kind of an answer for that. You need to, all the VA hospitals have a department of service connection, and I would start there and find out what your situation is and whether you can get higher than 10%. The sleep lab within the VA doesn't have the ability to determine any type of service connection. That's all done through a different department within the VA hospital system itself. So, you know, you can talk to your sleep doctors about it, but they're not going to be able to do anything. You're going to have to go into the VA hospital and talk to the service connection department.
Okay.
Looks like there's a question from a dear fan, Malik. Let me see if I can allow you to talk. Go ahead.
There's,
Dear fan, you have a question? Doesn't look like we can hear you.
there's, wonder why it's not working.
It looks like his mic is muted.
Oh.
Hello.
There it
can you
is.
hear me?
It's off now.
Hello, there he is. Hello.
Hello, can you hear me? Hello.
Yes.
Yes. Yes, we can hear you.
Okay. Thank you so much, Joseph. I really like your lecture. I am Dr. Irfan Malik, working as a pulmonologist in Pakistan and running level 1 sleep lab for the last 5 years. I have Philips device, level 1 Philips device. My question is, during titration for optimal sleep study, I need RAM of at least 15 minutes in spine position. In some scenario, patient, all events are gone, a saturation level is well maintained and patient remain in spine position, but there is no RAM. What we call this sleep study. And second question is, what is your opinion about new Cpap device which we apply in nose, nasal Cpap devices? Thank you so much.
Well, I think I understand a little bit of the question, but I have to go, part of this, I have to go back and remind you that I'm not a doctor, you know, so I can't give you a diagnosis as to what that is just based on that. But I think you said that can you tell me again about the REM side of things? I could barely hear you.
Okay, can you hear me now?
That's better.
Okay. My question is, I titrated a patient and patient achieve all target of sleep study, optimal sleep study. Only we are unable to achieve REM sleep.
Okay.
They were all events were there was no event, oxygen level well maintained, patient remain in spine position, but we were not able to achieve REM sleep. What we will label about this sleep study? Is it acceptable, or we have to repeat it again?
No, if the patient doesn't go into REM, it's acceptable. Carl, you may want to jump in on this, but it's acceptable because there are conditions that actually would cause a patient not to have REM. There's some pharmaceutical agencies that can cause that. There's other disorders that can limit the amount of REM that a patient has.
Okay.
The key that you're looking to have is, did the patient have sleep, and did the patient have enough sleep to be able to qualify for a successful polysomnogram?
Okay. Okay. Thank you so much, Joseph.
Yeah. I agree. In that particular case, just curious how much deep sleep you might have seen for that patient on that particular night. But Joe, I agree with your response.
Yeah, I think he's gone.
Okay. No, I'm listening.
Here?
Thank you so much. I agree. I agree what you are saying. Thank you so much.
Well, thank you for your question.
Thank you.
It looks like we have one more hand up. I don't have the controls, guys. I don't think so, anyway.
Okay, is my mic live?
Yes.
You are live, Bob.
Okay, 3 questions actually, if you have time. I work with truck drivers a lot. They're faced with the challenge of, if they get a 90-day conditional certification from a DOT medical examiner, is getting tested and treated through the VA system within 90 days, or they lose their job. Do you have any suggestions that we can give to veterans on how to expedite those?
Well, the first question would be, are they in the VA hospital system? Because if they're not, then that 90 days is going to come and go by the time they get into the system. If they are in the system, I know that most of our labs now, mine in particular, 3 years ago or so, we were scheduling almost a year out. But what we've done is we've doubled our size, and with the additional help of home sleep apnea testing, we're able to bring in patients that have to be in a bed for the PSG much sooner. We're pushing 30 days or so now in our sleep studies. So we've really shortened the wait time. And for us, and I think it's going to be the case in most VA hospitals now, you're talking a 2 to 3 week turnaround time after the sleep study to have it read, scored, and to bring the patient back. But then they have to go on to the CPAP. Is that what you're talking about, Bob? Once they're on the CPAP, or are we just trying to get them onto the CPAP?
Again, they need to be on CPAP at least 1 week before they can go back to the DOT medical examiner for a follow-up exam and, you know, continuation of their card. So if nothing else, maybe it's just a matter of raising awareness within the VA system of your patients who happen to be commercial motor vehicle operators. This can be a complication in their treatment.
Yeah, we have a lot of patients that are on the DOT ranks, and we're able to turn them in plenty of time. But again, I can only speak for my lab, but it sounds like it's a problem for other facilities across the country.
Again, the second question, you touched a little bit on service-related disabilities. There was a bit of a public media controversy that I personally don't agree with, but it was out there, about veterans being diagnosed with sleep apnea within 1 month of retirement, in part based on the service-related disability. Is that still a controversy, or is there any updates on that one?
I don't know if Carl has any information on that, but as I stated before, I work in the lab, and we are not even allowed to discuss service connections with our patients. It's a conflict of interest, because then that puts the burden on us to whether we're going to diagnose them with a sleep disorder or not. Our role in the lab is to do just that, to diagnose them. Then if they are diagnosed, then it's the service connection department within the VA that'll see if there's any type of connection. I'm not trying to escape the question. I'm just telling you that we're not even allowed to talk to our vets about a service connection.
Got it. Okay, the last question that involves active duty personnel. I don't know if you want to try this one.
Sure, I'll try.
Doing public screenings. Often I'll run into a active duty vet who screens high risk for sleep apnea, yet they have a very large reluctance to get tested, in that they've heard that it would prevent them from being deployed to any forward bases with their unit. Is there any updates you can give me or advice you can give me on trying to talk active duty vets into getting tested?
I have one of the things that's pretty interesting about the machines that go out now with having the modems is we also have machines that have Wi-Fi connections in them instead of modems, because a lot of the vets that are deployed don't have modem access, but they almost all will have a Wi-Fi access. So we have active duty military personnel all the time that are being put on PAP devices with the Wi-Fi modems. Now, how far up they're being deployed, I don't know, but they're definitely being deployed overseas and in the war zones with these machines.
And again, maybe to give some other, I was involved with a marketing effort with Transcend, one of the portable CPAPs, where they ran a batch of digital camo cases and digital camo machines with extra batteries for a series of, active duty orders. So, and they apparently deployed successfully. I'm just curious if there's any other follow-up on that one.
Now, not that I've heard. Now, I know that Respironics at one point had nice digital bags. I mean, camo bags that they use for the vets the active duty that were deploying. Hey, Bob, you're a truck driver, aren't you?
Correct, I am.
Yeah, I've met you before. You've done some lectures yourself, and you've talked about the problems of using CPAP in your rig.
Yeah, and again, a lot of the things that active duty run into from the practical side is very similar to what we deal with on the trucking side. So back when ASAA had its message board forums, a lot of those questions ended up getting sent to me because I could usually refer them to somebody that might have an answer.
Yeah.
But again, the VA system is complicated, so the more I can learn, the better answers I can give.
There's a saying within the VA that if you've been to one VA, you've been to one VA, and that's clearly a problem. Where we have labs that are running things one way in one city and run completely different in another city, and that's something that we're really trying to you correct. But I guess part of the problem is we're the largest provider of healthcare anywhere in the world. And sometimes the left hand and the right hand don't know what they're doing. But it is getting better. And it's because of people like you, who talk about it and hopefully, continue to post this information out there, as well as the ASAA for having this talk right here. I would put all this information on the ASAA Facebook page, and see what kind of response we get.
Okay, well, we are going to have to close. Thank you, Joe, for being here and helping us with this super important topic. And thank you to all the people that asked questions. And we will see you next time on Webinar Wednesdays.
Goodbye, everybody.
Take care.
Bye-bye.